as David said, I'm a psychiatrist at Baragwanth Hospital, and I have run the Luthando HIV Neuropsych Clinic since 2008. So we're busy in our 5th year of our clinic, and we're still kind of adapting and changing as things go along. So today I would kind of like to be a little bit of an advocate for mental health and integrating into HIV, number one. I'd then like to tell you a little bit about neurocognitive disorders, some of the drug interactions, speak a little bit about depression and personality disorders, because I think that's what you guys see quite a bit in your clinic. And then I have a number of cases, so because, I mean, this is a 2-hour slot, so I don't want to bore you to complete death. And then I'd like to tell you a little bit about our clinic and show you some of the results of our clinic and kind of what is the way forward in terms of where we need to go to integrate mental health and HIV care. All right, so you guys happy with that?
Yeah.
Fantastic. All right. So I found these 2 quotes, which I think are quite fantastic in terms of HIV is a neuropsychiatric disease with some somatic manifestations. And I think you guys will think it's the other way around. But I think this is where we're heading in terms of the HIV pandemic, really. And that we've got to start incorporating mental health into this whole HIV thing, so that, number one, not only can we stop the spread, but also 2, deal with the mental health of these 5 million people on ART. And what we have to do is create sound minds and sound bodies, and really there is no health without mental health. And HIV really has combined internal medicine and psychiatry like no other disease has. And a lot of the physicians think that we aren't real doctors, which a lot of psychiatrists aren't, because they're not really that interested in dealing with the somatic manifestations of HIV. And I'm sure a lot of you get completely cross when they go, please rule out general medical condition. And I get just as cross when our registrars do that. And I think it really is kind of our job to try and change that. And we've got to start integrating and deal with both things together. And I think this is a huge emerging challenge. This is the 4th pandemic in terms of mental health challenges, mental health issues. We've got to start looking at all of these mental health things. Just depression and neurocognitive disorders, because it has such a huge impact on the economy, socially, occupationally. And I think that's where we're kind of moving. I really hate it when people go, oh, HIV is a chronic disorder and we can treat it like diabetes. And, you know, we've got to start moving away from that, because yes, it is a chronic disorder, but at the same time, nobody realizes the impact that these neurocognitive disorders have on people. And it's the asymptomatic and the minor neurocognitive disorders that we really have to start diagnosing, treating, thinking about the economic and social consequences of that. So, you know, we've got to put a hell of a lot more input into prevention, especially amongst, you know, mentally ill people. Mentally ill people have been left out of all of these prevention programs that are going around. So mental health care practitioners, believe it or not, can be involved in not only helping you guys, but also helping to try and stop the spread of this pandemic, because, you know, mentally ill people are a vulnerable population, they're a marginalized population. Nobody really spends time with them, and so we're not putting them on treatment, we're not testing them, and so what are they doing? They're going out and spreading HIV, and we need to try and stop that and change that. Okay, everybody just has to look at some of the prevalence statistics, and HIV is huge in the mentally ill population. In America, it's about 76 times greater than that of the general population. But in Southern Africa, depending on what studies you look at, anything from between 0 and 60% of psychiatric patients are HIV positive. And I mean, that's huge. That 59% is a Zimbabwe study. But, you know, Pamela Collins from the NIMH, she was previously at Columbia University, did quite a nice study in terms of looking at the prevalence of HIV in mentally ill people, and kind of found that it was between 23 and 26%, so kind of similar to the prevalence in the general population. And she attributed this to injection drug use, basically less injection drug use in South Africa, and also very high general prevalence. But I think nonetheless we still have to realize that mental health or mental illness really increases vulnerability to HIV infection. All right, we know that people with mental health disorders are more prevalent to getting HIV, and the other way around, that people with HIV are more prevalent to getting HIV. And it's so important that we identify this and address this, because not only does it help with adherence issues, but would also really help in terms of positive prevention and us dealing with those kind of things. And it kind of makes sense that we need to integrate mental health and HIV care. However, there are so many other problems with regard to integrating care. We know that psych patients are vulnerable, and that HIV begins its spread within these vulnerable groups of patients. And really, mental health has to become the fabric of public health initiatives so that we can contain this and stop the spread of HIV. And I think you guys all agree with that. We've just got to try and work out the best way for South Africa. So, it's very hard to do these things. It's very hard to introduce behavioral interventions because we don't have the staff and the population, and we need to start involving the media more. One thing I love about HIV is that there's so many activists and there's so much advocacy going around, and mental health care practitioners are just in the background, and we have to take a lesson from you guys and start spreading the word about mental health and HIV, and get out there. We need to build capacity and network, and we can't be complacent anymore. But I think I'm speaking to the wrong people, because all of you are very passionate about HIV and very involved in its care. So, and this is the kind of thing that I keep on trying to tell psychiatrists, in terms of you've got to want change, you've got to prescribe it, you've got to advocate for it, and not just sit in the background and moan about us poor psychiatrists are in the background. So, we really have to start advocating for mental health and HIV. One of the big problems with HIV care and mental health is that so much money is being pumped into HIV care, and mental health is kind of falling on the wayside. So we need to try and make that equitable. So everybody knows this long round circle of mental health and HIV, and the impulsivity as a result of mental illness, the poor judgment, the lack of insight, increasing the transmission to acquiring HIV, and then also various the other way around. And unless we find a way to stop that circle, we're not going to change the spread. And integrated care, the two of them together, we need to start making a plan. So I can name a million reasons why psychiatrists should be involved in care, but I think, even if we're just talking about normal general HIV care, psychiatrists need to be there in terms of dealing with adherence issues, trying to get screening of common mental disorders out there. But the problem is, once you screen for these mental disorders, what do you do with the thing thereafter? And we know that mentally ill patients are more vulnerable, and all of those things we're all very affair with. But there's so many new wonderful studies, psycho-neuroimmunological studies coming out, and HPA axes and how HIV interferes with that. But bottom line is that unless we deal with the social and the poverty and all the other stuff that goes with it, the psychosocial issues, we're not going to stop that roundabout circle. We know that depressed patients are 4 times more likely to report lower adherence. So we've got to identify the depression and treat it. But how do you treat it when primary healthcare nurses that are rolling out ART can't prescribe an SSRI? So we've got to start changing those kind of lobbies and those kind of rules. And then trauma, childhood sexual abuse, childhood psychiatric disorders, and then also the behavioral disturbances of those patients, of those children who have HIV as a result of vertical transmission. We need to start dealing with that as well. We know that psychiatric patients in general are a medically underserved population. We know that psych patient, completely psychotic, goes to casualty, says that his left toe is completely gangrenous, but the Martians are invading his left toe. Nobody's really going to take him seriously. So, we know that they're a medically underserved population. We know that those patients with triple diagnoses, substance abuse, mental illness and HIV, have really a decreased access to initiating heart. But we know that patients just with HIV and mental illness actually, well, in America, not in South Africa, have increased access to heart because mental health is so involved in HIV care there. We know that they're a highly stigmatized population, doubly stigmatized, triply stigmatized. We know that those patients with substance abuse, that is a real big barrier to accessing care. The other big thing that I'm always going on about is that a lot of the general physicians and the general ART rollout people, the moment you present with a mental health disorder, there's this perceived they're going to naturally be non-adherent to their ART. And that really isn't necessarily the case. So we've got to change that professional stigmatization. There's no communication between HIV doctors and psychiatrists. I don't know which way it goes, if the psychs think they're way too important to speak to the HIV, or if it's the other way around, I'm not sure. But we really need to start communicating more. And if we're going to stop this pandemic, we need to, kind of work together. There's no case managers. When I was in Cleveland recently, each HIV positive patient gets assigned a case manager who follows them up and, goes to their house and makes sure they take their treatment. When are we going to start developing a nice system like that? People think that they're toxic central nervous system side effects to ART, which we need to also start, dealing with and dispelling those various myths. And people are horrendously scared of drug-drug interactions, which they really shouldn't be. I'm going to show you a few slides on drug-drug interactions, and there's one or two common ones that we kind of need to be aware of. The rest, really, you don't need to be stressed about. So we need to have one voice, we need to integrate care, and Luthando is one model of integrating care. It really isn't the be-all and end-all, because I still sometimes wonder about the sustainability of the model that we have. But we've got to start talking one language here. So one of the big questions is, do you take mental health to HIV, or do you take the HIV services to mental health? And as a result of there not being huge capacity, and because of the professional stigma and all of that kind of stuff that happened in the past, I decided just to take HIV to the psych clinic, which was a problem in itself because I had to learn HIV and I had to learn all the different drugs, and I had to start dealing with TB and all the other opportunistic infections, MDR and all of that kind of stuff, which many psychiatrists are not, kind of willing to take on. But, I'll show you a number of models that are so easy just to start integrating mental health care into your general service. So why is it that we haven't integrated care? Why is it that, the primary healthcare nurses that are rolling out ART are not taking on mental health and are not screening, treating, referring and what have you? And this was quite a nice article that I read recently by Sumaya Moore from UCT. And she was asking, is it knowledge? Is it training? Is it support and supervision? Bottom line is, in that article, they said that people are scared of psych patients. They're worried about their own safety. And I think a lot of you are worried about them, but, and then there was this unwillingness, and they kind of said they're overburdened and they've got too much work. And they kind of just, psych must do this, and we kind of can't have that attitude of psych must do this anymore. So my clinic is really a supermarket model. I've got kind of a one-stop shop, which is not necessarily probably the right way, but my aim is to make it more accessible, make it more affordable, and with a minimal amount of disruption in patients' lives. But that doesn't necessarily mean that these patients are less stigmatized or less marginalized, because if you put a whole bunch of people together, the mental health care then is kind of ignored and not adequately treated. So we've got to find quite, the balance between the two. And this thing about funding, if we try to integrate mental health into primary health care, all the funding goes to primary health care and mental health still gets put aside. So we have to try and work out in terms of funding. But then, the complete opposite is also just as true in terms of stigma, that if you put a number of patients in a waiting room, then you can't really identify unless they got complete TDs and are drooling in the corner. But, stigmatizing in that way is then completely the opposite. The other thing is that there are not enough mental health care practitioners out there, and we have to try find a way of increasing the service and trying to kind of share the workload, which you guys think that psychiatrists don't do much, but we need to try and change that a bit. Then we've also got this horrible thing called deinstitutionalization, where they're trying to do community care, chronic community care for schizophrenics and all of those kind of things. And there's more and more psych patients in the community, and you guys are going to be seeing more and more patients. You know, we've got 160 beds at Barrow for psych patients, but they're completely full. We've got a 99% occupancy rate. So, you know, we tend to be discharging patients prior to their time when they're supposed to be discharged. And so we have to start doing more in terms of the community. So this was a wonderful article. I mean, I think everybody knows Vikram Patel from the Lancet series, Pamela Collins from Columbia at that time, and Melvin Freeman, who's now the director of non-communicable diseases in South Africa. And in 2005, he was calling for this integration. He was calling for integration between mental health and, you know, rolling out mental health in general, HIV clinics and what have you. But what has happened? That was 2005. Why haven't we listened to him? Why haven't we changed things? What is it that's stopping? And, you know, he said that there's so many lay counselors out there in the general HIV clinics. There's so many nurses out there. All the money is going into primary health care. Why aren't we using those services? And I suppose it's a good question. Why aren't we training lay healthcare workers? Why aren't we training the nurses in identifying common mental disorders and treating them? Why aren't we lobbying for changes in prescribing tactics? He was calling for increased in research and looking at cost-effective analyses and various things, and we still haven't done that. And he was calling for advocacy, which we still haven't done. So obviously mental health matters. Mental health matters in terms of depression and adherence. Mental health matters in terms of substance abuse and increased transmission of HIV. And then the cognitive impairment, which I don't think people realize, the asymptomatic and the minor neurocognitive disorders really have a huge impact on socioeconomic, on driving, on various other occupational jobs. Right, okay, so the question is, do you partially integrate? Do you fully integrate? Do you just talk more? I think bottom line is we can all just talk more to each other and communicate a little bit more. So we're trying to integrate HIV and TB care. Now we're throwing substance abuse in. Now we're throwing psych in. You know, who's supposed to do all these jobs? 4 jobs in one. We know that integrated care can lead to, you know, improvements in health, improvements in adherence. Health outcomes, I think, you know, generally we all realize that integrated care can do this, but does it actually decrease cost? And this was a very disheartening article to read, which came out last year, and it just showed that cost effectiveness of integrated care for triply diagnosed patients was not more cost effective, and the outcome in terms of, you know, their activities of daily living and what have you wasn't necessarily better. So that kind of put a bit of a spoke in the wheel, but what we need to try and do is do more of this research in a South African setting to see if integrated care would be cost effective and improve health outcomes. So no health without mental health, and I think that needs to be a general slogan, and we need to start rolling that out so that we can just make sure that holistically we treat patients together. Okay, so that's enough about going on about integrated care and advocacy for psych, but what about depression? I think if we look at all the psychiatric disorders, depression is definitely something that you can identify, diagnose and treat quite easily. So there's a number of ways that one can do this in terms of screening. There's a number of self-report. This is easy for America. You roll out, you put all these screening instruments in the waiting room and the patients fill it out. They'll work here. People don't have pens, people can't read and write, the literacy rate is huge. So we definitely need to work out a bit of a different plan. Nurses don't have time to give out these screening tools. Patients can't do them themselves. So what are we going to kind of do? These tools are great because, you know, you kind of get a score at the end, and depending on what the score is, they kind of give you an algorithm. I'm still very worried about these algorithms in psychiatric care, rolling out algorithms. You can't put a psych patient in a block and make him follow an algorithm. And I think that's one of the reasons why it's so hard to, you know, roll out mental health care, because, you know, each patient is different, and we've got to kind of individualize treatment for each patient. So kind of, instead of rolling out these questions, all I want is for nurse practitioners or, you know, those general GPs out there, or general physicians, to kind of just ask 5 questions. And these kind of 5 questions cover depression and anxiety, suicide, neurocognitive disorders, and a past psychiatric history. And maybe, you know, you could add a question on substance abuse or deliver the cage or something like that. So, I mean, 5 little questions. Why can't, I mean, the question is, why can't nurses do it? Well, we know they're overburdened, we know they have stress, we know that they're scared, because once they diagnose it, what do they do with these illnesses? Send it to psych, psych says, no, sorry, exclude GMC, you know how it is. Okay, but they're wonderful models. This is the friendship bench model, which is a model from Zimbabwe, which I really, really like, because what they did was they took a little bench, they put it out under a tree at a general CCMT clinic, and it was the mental health chair. Now, a lot of people can say that's quite stigmatizing in a way, but if anybody had a social problem or a mental health problem, they went and sat on the chair, and all these little counselors that were trained in quite important problem-solving type of therapy. So, you know, it's not very involved in terms of CBT, but it's, you know, kind of just solving problems. And it was a 10-week program, and they kind of sat on the chair and they did this. And I think that was really a wonderful way in terms of identifying these people, making it less stigmatized, and also, you know, doing something for depression. Okay, so I kind of thought, well, here's a case. Let's talk about a case for depression, and at the same time we can look at drug-drug interactions, what you should be using to prescribe, and some various other psychosocial issues. Okay, so 35-year-old female diagnosed with HIV a month prior to her presentation. On inquiry, she has a depressed mood, insomnia, no appetite, decreased concentration, lots of worries, lots of somatic complaints, bilateral peripheral neuropathy, coughing for the past month, lost a huge amount of weight, CD4 is 203, viral load is 150,000, sputum is positive, you start her on TB treatment, Rifampicin. 2 weeks later, you put her on 3-TC, TDF, and efavirenz, and 1 month later, you know, she's still very depressed and scores quite very highly on the Beck's depression inventory. And the number 2 version is really, you know, specifically for HIV/AIDS. So as you can see here, there's a number of questions that one needs to ask. One needs to ask, should you have treated her before you treated it? You know, this is identifying depression in somebody with quite a severe medical problem. There's the interactions between Rifampicin, and then there's also 3-TC, TDF, and efavirenz. Is that the appropriate regimen for this patient? So I was wondering if you guys could, you know, tell me a few things in terms of when is the right time to prescribe antidepressants. You know, I work at the hospice sometimes, and as they come in, I give them Cipromil at the door. Don't ask them questions. But is it appropriate to do that, or is it more appropriate to kind of, you know, wait until you've treated things and deal with things in a different way? And what antidepressants would you use? I know that Barra's run out of Prozac, Barra's run out of Cipromil. We don't have antidepressants at the moment. So what are we supposed to use? And I think you guys in general practice are also kind of limited in terms of you only have tricyclics. I mean, everybody has amitriptyline, and is it appropriate to use amitriptyline in these patients? Let's hear what you guys have to say. Have I scared you completely?
Yeah, no, I think let me start and then we'll see what the other guys say.
Yep.
I think we miss depression all the time. And I think as I see our patients up in Helen Joseph, for instance, I think most of them are depressed. But one feels that probably the antiretrovirals will make them feel better because it will enhance their kind of control the virus and enhance their immunity and will fit and will work after a while. What I see is that in the Head and Joseph we're using amitriptyline primarily. I don't see any fluoxetine or any of the others at the moment. Would I start this lady on antidepressants the moment I saw her? Probably not. I'd probably wait and see how she responds to the antiretrovirals. But I'd like to kind of hear what the others say.
Yeah.
I think we give amitriptyline if they have insomnia. So it helps their feet and it helps them sleep.
But does it help their feet?
No.
It does.
No.
You think?
No.
It doesn't.
Really?
Okay. You seriously think it helps their feet? Yeah, okay.
Not at all.
I agree with you. Okay, so first of all, what doses of amitriptyline are you using? Let's talk about some of the problems with amitriptyline, some of the advantages of amitriptyline, and then dosages.
We start with 25 milligrams and then we can easily up to 50. And after a while, the patients get used to it. And when you want to stop the amitriptyline, they say, no, doctor, we need it to sleep.
Okay. Can I be like totally inappropriate in terms of saying to you that that is like a silly dose, you know, of amitriptyline? Push it up. You know, obviously you've got to be very careful in terms of, you know, some of the cardiac side effects and too much sedation and, you know, the potential for overdose and suicide. We've got to worry about that. But 50 milligrams, you're doing nothing, you know. If you want to adequately treat depression in those patients, go up to, you know, push it up slowly, but go up to 125, 150 milligrams of amitriptyline.
Is that not too sedative?
Well, if you go slowly, it isn't. Like you said, they kind of get used to it quite quickly.
When you say slowly, how slow? Over every 2 weeks?
Well, I kind of go 25 milligrams for a week, 50 milligrams for a week, and then increase every 3 days, you know, about 25 milligrams. But obviously you've got to be kind of wary of so many other things. So be careful, but also kind of, you know, don't be too scared. What I'm trying to say is that don't be scared to diagnose depression and don't be scared to aggressively treat it. You know, choose the right drug in the right patient.
I agree.
Yeah.
Can I ask, if you put her onto a PI, say Olivia,
Yeah.
how would you feel about using, say, 150 milligrams of amitriptyline and the effect on the cardiac function, particularly QT interval?
Okay, so HIVdruginteractions.org is a nice website to go onto if you're very worried about things. Sometimes I'm a little bit scared of what they pump out, but this was about a year ago that I pulled this off their website. And if you look at, I mean, it's quite nice because you put in your drugs, you put in the potential drug, and it spits out various drug interactions. So if we look at amitriptyline, you know, with lopinavir, ritonavir, yes, there are some drug interactions, but it definitely isn't, you know, completely contraindicated. And look, my choice of antidepressants would not be a tricyclic right in the beginning. So I would definitely go with SSRI, and specifically citalopram, or you know, fluoxetine. You've got to kind of be a little bit careful with fluoxetine, or sertraline. Sertraline is a really nice drug. However, at Barra at the moment, no Prozac, no Cipramol, so we've got to go with amitriptyline. So if you can just monitor, go slowly. I think in those cases of PIs, I wouldn't be too stressed. Yeah.
Dosages for kids of your, I work in a primary health clinic, we only have the amitriptylines. 10-year-old child, what would you start with?
First of all, in kids, I know that, you know, the child psych unit at Barra is not using tricyclics, obviously, so they're going with citalopram or Prozac, and they're going with 10 milligrams and then pushing up to 20 normal adult doses.
We don't have those. I mean, I know that psych unit at Barra, I've had kids there too, but the primary health clinic,
Good or bad?
we don't have them. What do we do with the kiddies?
Well, look, I mean, you know, imipramine is kind of safe in terms of helping with enuresis and all of that. I mean, if that's all you got, you really think the kid is depressed, go for it, you know. Well, but also,
It's just we can't get the drugs. I mean, we just had a case which I won't bore you all with, but it's so hard
At
to get
Barrow?
out there. No, this was actually at Alex. And it is so hard when you don't have the drugs and that depression is so real in these teenagers, and we end up having to refer it to Barrow.
okay, but there is a psych clinic at Alex, East Bank.
Yes.
Why don't you just try and get it in there? Get the child in
Thank you.
there.
No, we have it takes a while, but those statistics. But yes, East Bank is.
Yeah, but if you've got amitriptyline, well then use it rather. I mean, rather than the kid having a disastrous childhood and, if that's all you got, use it. So don't be scared of amitriptyline. All right, now what about the ART in this woman? Are you happy with 3-TC, TDF, and efavirenz in this case? You all happy with that?
No.
Okay, great, fantastic. Why? Why are you not happy?
We know that efavirenz has major problems in terms of people's depression, worsening depression, suicide, so that would be a worry from my side, really.
Okay.
I don't know how the others feel.
Okay, so a psych patient, depression, or even psychosis, would you all stay away from efavirenz?
Yes.
You would?
Well, the only problem is this person's got TB.
Yes,
So
okay.
you're restricting your ARVs, and you also, one has to bear in mind, even the PIs, you're not going to use them, you have to double the dose. So one is very restricted, you have to take the whole patient into consideration.
Okay, exactly.
You have to.
So this patient, the TB is a big issue.
It's Rifampicin and
Exactly. Okay. So you are restricted, but what I also want to tell you is do not be scared of efavirenz. More than 60% of the patients in my clinic are on efavirenz and they're actually doing very, very well.
Sure.
The recent meta-analysis that came out early this year was also saying only 6% of patients actually have to stop efavirenz as a result of the neuropsychiatric side effects. So don't not give it to psych patients. And actually it was advocating a little bit to give it, because of nevirapine, some of the issues and the doubling of the dose and all of those other things with Illuvia and what have you. So don't be scared of efavirenz. And I would put this patient on efavirenz. And I did put her on efavirenz and she did very well. Okay, are there any other questions that I wanted to... Okay, drug interactions with Rifampicin and antidepressants. Any ideas? Anything that you're worried about? Yes, okay, who said that? Yeah?
Me.
Yeah.
I just know you're concerned with epileptic patients on efavirenz, or we give them epilim as opposed to...
Okay, seriously, you're worried about epilim? Okay, I wouldn't be worried
No,
about
with
epilim.
Rifampicin.
Oh,
I'm talking
okay.
about
Yeah.
and anti-epileptic drugs, that's what I'm saying.
Okay, so
Change them
to what?
to epilim.
From what?
Phenytoin sodium.
Yes, okay. I agree with you completely. I hate phenytoin, terrible drug. So epilim is a great drug in terms of this. But don't worry about drug interactions with Rifampicin and citalopram Rifampicin and sertraline Rifampicin and even some of the amitriptylines. I wouldn't be too worried there. Okay, Prozac, there might be some CYP3A4 and 2D6 interactions, but nothing that you're going to have to increase the dose of Prozac for, decrease the dose of Prozac for. So there are interactions, theoretical interactions, but what is the clinical significance of that?
I think, Greg, if I can butt in, I think for most of us as clinicians, we use SSRI and those kind of drugs so seldom that we have a fear of them. And I think just listening to you reassures one that one can use it and you're not going to kind of do something dreadful to the patient. So I mean, just listening to you right now kind of says, hey, we should be actually being a little bit more robust in the way that we're managing our depressed patients.
Exactly. I mean, what are some of the, what should one be really worried about if you aggressively treat depression in these kind of patients? Yes, like what is the percentage of these patients switching into mania? It's not huge. And if they do switch, well, you stop the drug and you add a bit of epilim. So I wouldn't be too stressed about, I'm going to push him into a manic state or something like that. I mean, what else? You know, physical interactions, cardiac, you know, with SSRIs is not huge. So use it, seriously. I wouldn't be scared. So use it, maybe if you're getting to like 50 milligrams of citalopram, then you're kind of starting to worry about QTC prolongation. Maybe 60, but how clinically significant? You know, citalopram has just come out with a black box warning of QTC prolongation with high doses of citalopram up to 60 milligrams. But, you know, I wouldn't worry at 20 or 40.
I think also you're using so much amitriptyline, but SSRIs have far fewer side effects and drug interactions. So why are you scared of them when you're using a much worse, dirtier drug?
Exactly, exactly.
Already.
So please, you know, go for it. Use citalopram and use sertraline is a very great drug. There's so many generics available that the actual, you know, the prices come down hugely. We're getting this horrible drug from India at the moment called Xylift or some other thing like it. I'm not supposed to say that, but you know, those kind of drugs we're finding that we have to double the dose just to get an adequate effect. So, you know, 40 milligrams of some of the generics as compared to 20 milligrams of the ethical drug.
I just have a question with this case. You've got a case that's starting TB treatment, initiating on heart, and we're going to give another mental health thing.
So you're worried about
the timing of everything. You can have an iris when you put them on heart. There's the TB drugs. I mean, clinically they're difficult to manage because you've got to put the patient into context.
Sure.
And you've got a pill burden, you're not sure, often they're not in stable circumstances.
All I'm trying to illustrate with this case is all I want you to do is just be aware of the depression and don't be scared to treat it. That's what I'm saying.
So when did you start and when did you start?
As she came in.
So you started with, it's interesting, so you started with the depression, okay, and then you started...
Well, I kind of did everything in, you know, together. So obviously I didn't go with, you know, ART right away. So I treated her TB, but put her on TB treatment plus an antidepressant, and then 2 weeks down the line started ART, and you know, she's well. Don't be scared.
So you can start the depressant.
That's what I would do. Yeah. Because I mean, what other alternatives do we have? Maybe if they were in the States, you know, maybe there's a good counselor, there's a psychologist, there's a good social worker. It wouldn't happen here. Yeah, so, you know, in those kind of cases in the States, you know, one would be different. I think we've got to kind of be pragmatic and a little bit more practical in this country of ours. Okay, so I hope I haven't confused you more. Okay, so, right, bupropion, I think you've got to kind of be a little bit worried about. Look, don't worry about too much of the drug interactions. Worry a little bit with the PIs, and in some of them, like paroxetine, you might need to increase. Bupropion, you might need to increase. Fluoxetine, and this is why I sometimes stay away from it, but when you've only got fluoxetine, use it. Sometimes with nevirapine, you may need to increase fluoxetine dose a little bit. With efavirenz, the efavirenz concentration goes a little bit up, so you may start to get some toxic side effects of efavirenz. But we'll talk about that a little bit later. Trazodone, I would be very wary some of trazodone because you have to decrease the dose of that, and alprazolam the same. But I mean, we're lucky we don't have alprazolam, although it's a wonderful drug and makes you feel like $1 million. It's got lots of interactions, so you've got to decrease the drug there. Okay. So what about suicide? This is something that we do need to be worried about. We do need to start screening for. We do need to look for. And our study that came out of the GEN just last year was that they took all their ODs and they saw that, you know, about 6% of all their ODs were ODs on heart. And I think that this is also something that I don't think we're equipped to deal with at the moment. And we don't have enough psychologists, we don't have enough social workers, we're not adequately screening for these patients. And yeah, so what are we going to do? And I think a big question there is, when exactly do you restart the heart straight after they've OD'd on it? Any ideas?
Do they OD because of the heart?
Well, this is what...
OD on the heart?
Well, OD on the heart, because of the heart, because of the HIV, because of the depression, because of everything else, because of the country, because of the social, because of the poverty, because of all of that.
Yeah, but our rule is don't stop the heart unless they stop toxicity of the medication. So that means we cannot stop the heart because
cool, fantastic. So straight after OD, put back on the next day. So what you're saying?
What did they OD on?
Yeah, no, exactly.
I mean, what are you looking at?
Sure. So OD on, let's say, 50 tablets of your favorites.
That's what I was
Yeah.
asking. So OD on their treatment.
Yeah, because they're ODing on their heart. So that was, one of the big questions. But anyway, I think what we've got to worry about is that 6% of ODs are on heart. Okay, so think about that and just screen for it properly. We all know the risks of suicide at times of stress, bereavement, anniversaries, social stresses, unemployment, stigmatization, hopelessness, and then also neuroticism. I think that's something that we'll talk about just now in terms of personality disorders. But social support, I mean, it's a very real problem in South Africa. How are we going to do something about that? Okay, so personality, and I think all your difficult patients, you guys refer to me, and my clinic is filled with personality disorders at the moment, so I'm a little bit cross with you for that. But there's so many personality disorders, and these are difficult patients to deal with in terms of adherence, in terms of their comorbidity with substance abuse, and I think this is quite an important thing to know what sort of person that has the disease and not what disease the person has. And I think we've got to kind of look at obviously all of this in context. But if we diagnose a personality issues, let's call it personality issues and rather disorders. If we diagnose it, at least we can start to expect their type of behavior and kind of look at their patterns of dealing with certain non-adherence and medication regimens and what have you. But also at the end of the day, if we're diagnosing the personality, we can also, tailor-make their prevention and positive prevention tactics that we're going to be using with them, because they're very impulsive, because they're unstable, because they are extroverted patients. And this is a nice Isaac's personality circle, and I think it's a lot more useful in terms of looking at personality disorders instead of dealing with DSM-4 criteria, which you need 9 of the 4, of the 2, of the 1. So, I mean, if we just look at, these are some of the personality characteristics which have led to patients developing or contracting HIV. They're extroverted, highly impulsive, unstable patients. And these are the patients that are generally going to be non-adherent to their medication, generally going to be substance abusers, and are generally going to give you a very hard time. So I think important is that, they very much deal with their feelings and not about their thoughts. It's, very impulsive. Despite them having the knowledge about you telling them that they're involved in risky behavior, they still go ahead and are involved in risky behavior, involved in substance abuse, and it's all about pleasure-seeking behavior and, going into these risky sexual situations to try and calm that anxiety, because it's very, very difficult to just be for these patients. So, 10% of the generally non-HIV infected patients have personality disorders, but in HIV patients it's a lot higher. Up to about 36% of patients, are either antisocial or borderline. Antisocial a lot more in America. I mean, I don't see that many antisocials. I'm seeing lots and lots of borderline patients, but not so many antisocials. They have high rates of substance abuse, and obviously it affects risk. So it's something that we need to be aware of and that we need to be appropriately treating. Because these patients are difficult, they split, they go to one healthcare provider, they go to another, they get this from you, they get that from somebody else. And if we're not communicating properly, we're not going to give these patients the best care they can get. HIV has all the characteristics of a disorder that is going to be non-adherent. I mean, we know it's long duration. They have these periods of no symptoms. Sometimes complicated medical dosing regimens. They're unstable, impulsive patients. So, now we go and add personality into the mix, and we really have a disaster in terms of adherence. So it's something that we need to deal with. All right, now some just general, very, very simple things that, I don't know, maybe I can impart to you in terms of how do we deal with these patients. We're always asking patients, well, how do they feel? Well, with borderlines and unstable impulsive patients, you know, we don't need to be talking about feelings. We should be focusing more on thoughts because they're quite impulsive. So instead of how they felt after, we need to start dealing with the thoughts of when they were doing that impulsive thing. Behavioral contract, I make all my patients sign a contract, and we focus on treatment goals rather than, you know, I'm very famous for saying I'm going to book you a bed at Avalon Cemetery because you're dying and you're full of nonsense and I'm tired of you. But, you know, we've got to start focusing on goals, and instead of, you know, oh, you're going to get sick, rather let's focus on, okay, increase your CD4, decrease your viral load, and this is what you've got to do in 6 months. And this is something we've got to coordinate with each other because they split big time. I mean, that's part of their primitive defense, and we've got to try and deal with that properly. So obviously keys to success is firm boundaries, firm set of expectations, willingness to focus on treatment goals and not generated by their feelings. Okay, so this is a difficult case, and she's still giving me huge amounts of problems, and I hope you can see. She's 29, she's the daughter of a matron, and she's separated from her husband, 4 kids. You can just see chaos. 3 live with her, 1 lives with her husband. She was diagnosed with HIV 5 years ago, changed to regimen 2 a year ago, has had TB twice, and now she's got MAC. On chlorothrocipro and ethambutol, defaulted her last treatment visit, and this is what she constantly does. As you're about to lock the clinic door, she comes. She's in a high-powered business suit, lots of makeup and what have you. Please give me my treatment. After she's missed 2 appointments. Okay, you just want to hit her. You've had a very stressful day. All you want is a glass of wine. I don't know why I put Grey's Anatomy because I hate it. That's all you want to get home to watch. You've admitted her twice. She's on an antidepressant. You've referred her for family therapy, for individual psychotherapy. Her psych meds, you know, I really tried very hard in terms of trying to put her on the right meds to improve her mood, improve her adherence, help with her impulsivity. And her IHDS is 11 and her BDI is 8. So not depressed, not too cognitively knocked off. She just really infuriates me, and I told her to disappear and I don't want to see her again. So, you know, and this is a big problem with these kind of patients, because you kind of feel that all you want to do is help them all the time, and so you violate boundaries with them to try and think that you're helping them. So is it the right thing to send her away at that time? Or do you actually just prescribe her and let her go off to the pharmacy because you're not sorting out the problem? Send her away. Okay, but now she's going to have a period of treatment.
She must deal with it. She must actually take responsibility. Her problem's not adherence.
Okay, but how can she take responsibility when she's a PD? You know what I mean?
Well, we give her a day soup.
Okay, yeah, so she's violated your contract. I've done a million contracts with her. I've bent over backwards for her, and now it's time to let go of her. What do you think?
I'd give her a pause for 1 day and she comes back tomorrow.
Do you really think she'll come back tomorrow?
No, well, she will, because if she runs out of pause, she comes back, you see. And if she comes 7 days in succession for 1 day's worth of pause, eventually she'll get the message. Okay, all right, so to be very rigid, dots kind of approach. Yes. All right, okay. Treatment buddy. Her mother's a matron, which is a problem. Yeah, but all their buddies.
Yeah. Well, no, that's a problem, yeah. Okay, so how do you guys feel about actually saying to her, right, I'm not giving you any more treatment, you go home, you decide, when you're happy to restart treatment, come back to me and I'll be very happy to restart you. But right now, I'm stopping everything.
All her treatment or her psychiatric treatment?
ART.
I wonder if you don't have to do that, Greg, from time to time. Because you in fact have no real way of controlling what's going on anyway. You don't know what's going on. And you'd have to check a viral load. And what are her viral loads like? Are they under control when you do that?
Her viral load currently is like 150,000.
She's non-adherent. She's non-adherent.
Okay, so kick out, goodbye.
But by you deciding to stop the medicines, you want more making a decision for her. And what she needs more than anything is tools to work out how to make decisions for herself.
Okay.
So if that can be flipped into a way where she makes the decisions, where she's put on the spot. But as soon as you make the decision, you let her off the hook.
Okay, cool. Very good point. Very good point, yeah. So what do I do with her? She's a real problem. She's supposedly coming today. Help me, I don't know what to do with her.
Order wine now.
Okay, anyway, so a difficult ethical case, but also a difficult treatment case. And her big problem is she doesn't want to engage in therapy. She doesn't want to go to Tara Ward 4 and 5. So until she's ready for all of those things you were talking about, I've tried in terms of boundaries and what have you. Psychologists has tried. She just never goes back to psychology. So she's sick. She's medically very, very sick at the moment. So this is a I'll book you a bed at Avalon Cemetery kind of case. Anyway, right, substance abuse. Obviously, substance abuse has a big role to play and is a big problem. I'll tell you, in my clinic, I don't have too many substance abusers, and I'm not too sure why that is. And even in our substance abuse clinic, our prevalence of HIV is very, very low. So what that is about is, I'm not too sure. Is it dacha smoking and they're completely amotivated and they can't get it together to have sex? I'm not too sure. Or is it, do they have amotivational syndrome, or kind of, where are we going? But we do know that, substance abuse plus HIV leads to a worse prognosis and a progression of the illness per se. Then there was this hype last year about smoking ephedrins. I don't know what you guys feel about that, if you actually really feel that it was true. One or two of my patients, I have caught them selling their ARVs, but are they smoking it? I don't know. What are you guys thinking?
Doesn't give you
I think it's an insult for real smokers.
Okay, if we talk about other substances in terms of methamphetamines and tuk and stuff, which is a big problem in the Cape, not too much of a problem here, although it's increasing. That obviously is a huge problem in terms of neurocognitive disorders. So we need to start thinking about stimulants, amphetamines, methamphetamines, and also in terms of risk, and especially in the MSM population and also the personality disorder groups. We're seeing a bit of cocaine, but a lot more heroin, which is in your pair. They're mixing heroin together with dacha and they're smoking that, which we're seeing a bit of, but not as much as what they're seeing in the Cape. Okay, so substance abuse is also difficult patients to deal with, because it's very hard to be empathic and non-judgmental towards these patients. And then, they lie to you and they're quite deceptive in so many ways. So how do you get a reliable collateral history without, worrying about confidentiality issues and disclosure issues? But you've got to get a proper substance history and a drug treatment history, and, looking at their triggers for their drug usage. I think we need to concentrate on this. Administering the CAGE questionnaire, sometimes a bit useless in a population that is deceptive. But bottom line is one has to look at dual diagnoses and triple diagnoses, because at the Johns Hopkins Clinic with Glenn Treisman, about 44% of his patients have dual diagnoses and 23% have triple diagnoses. So, and we know that these patients have a lot more affective disorders. So we've got to start treating those affective disorders, and hopefully we'll try and stop that. circle. But, you know, a big problem comes in, you know, was it the depression that led to the booze, or was it the booze that led to the depression? And, you know, trying to find out chicken and egg and which one came first. Just like, you know, the TB case which we looked at earlier. But I think, you know, bottom line is you've got to simultaneously and equally treat both disorders. You know, using motivational interviewing, determining pre-contemplation, contemplation, action stages, maintenance phases, getting them involved in a 12-step program. I don't know what you guys feel about 12-step programs in South Africa, but, you know, I walked into the clinic the other day. Maybe you should stop recording. But, you know, we had a group of dacha smoking guys from Soweto, and they were all holding hands and doing that AA slogan at the end. And it just, you know, it's such a Eurocentric model, and does it work in this country? So we've got to think of a proper South African 12-step program, and maintenance of relapse and proper rehabilitation for these patients. Do you know that there are very few rehab placements in this country? I mean, we've got Magali's Oort, which is government. I mean, other than that, we've got a number of NGOs that have sprung up quickly, but I mean, are they helpful? I don't really know. We've got a dual diagnosis unit at Sterkfontein, but they also have very strict criteria, so it's very difficult to get patients in there. So I'm sure you guys have a big problem in terms of what do you do with these substance patients. Right, okay, do you guys want to break, or should we motor on?
You're doing fine.
Okay. All right, so let's address the neurocognitive disorders. And HIV neurocognitive disorders, 3 different types: asymptomatic neurocognitive impairment, mild neurocognitive disorder, and then the one we're all very familiar with, which is HIV-associated dementia. Common, very, very common. In a study done by Jonsson in Cape Town, obviously almost half of the patients had asymptomatic, at a general HIV clinic, had asymptomatic neurocognitive impairments, so stuff that we're not picking up. It's not affecting their activities of daily living, but they definitely have cognitive fallout. Importantly, it can develop at any stage of the HIV infection, and it has real implications in terms of adherence, medication adherence, and then socially and occupational outcomes. And obviously also associated with risk behaviors. Now, what is also very important is that neurocognitive disorders are still very prevalent in the area of heart. That even though we're prescribing heart and we're hoping that heart is going to, you know, kill off the virus in their brain, it's still very, very common. We've done a lot in terms of the incidence of neurocognitive disorders, decreasing that with heart, but we've done nothing with the prevalence of the asymptomatic and the mild neurocognitive disorder, and that is still increasing. Okay, so John Joska's clinic, you know, just a normal HIV clinic, mild neurocognitive disorders, 42% of patients had mild neurocognitive disorder that you know, wasn't picked up, wasn't being dealt with. And what are the socioeconomic implications of this illness? I think everybody knows about the pathogenesis of neurocognitive disorders in terms of direct model with the viral proteins attacking you know, various structures in the brain. We've also then got the immune activation, the nitric oxide, arachidonic acid, the cytokines, pro-inflammatory cytokines, which all play a very, very important role in the pathogenesis of this. Now, how does one diagnose this? It's kind of hard to do in a very busy clinic, but what one has to really look for is look at cognitive domains. And there's 8 different cognitive domains that one has to look at. And then also look at the level of impairment in terms of social and occupational functioning. So the old guidelines from the American Neurological Society had a lot more in terms of behavior and personality changes and what have you. That's been taken out of the new guidelines, and it's very much looking at cognitive deficits, but also this is very difficult in South Africa because we don't really have norms for various, you know, looking at various cognitive domains. And then also, how does one diagnose level of impairment, you know, in a population that is so very poverty stricken, so nutritionally impoverished in so many ways. And how do you get a reliable support and a reliable report for these patients? So, asymptomatic neurocognitive impairment has no impact on activities of daily living, well, supposedly. And one has to then look at these various cognitive domains. So look at verbal, language, attention, working memory, abstraction, memory, speed of information processing, and some of their motor skills. And I'll show you a quick and easy way of quickly looking at some of the more important domains. The specific deficits are trail making test, substitution test, controlled word association test, and these are a whole bunch of neuropsychological tests that are very difficult to administer and take a very long time to administer. So one of the big problems in South Africa is we have to find a screening tool that is not just screening, but it's also not a complete neuropsychological test. So somewhere in the middle. All right, the mild neurocognitive disorders is again a impairment in those various cognitive domains that I showed you. One standard deviation below the norm, whatever that means in this population, but also then mild interference in daily living. And I'll show you one or two cases in terms of, what is impairment in daily functioning. So it's mental acuity, inefficiency at work, homemaking, social functioning, or a report by somebody else. And then I think everybody knows what HIV-associated dementia is. Again, the cognitive impairment, but a much more moderate to severe impact on their activities of daily living. Okay, so I think what's important to know is that you get the mild, the moderate, and the completely severe. Okay, so one can use the Folstein's mini-mental status examination to diagnose these. A little bit long to do, I suppose, in a general consultation. But if you look at the mini-mental status exam, it's divided up in such a way that it kind of maps certain parts of your brain. So, the registration and the recall gives you a lot of verbal learning and verbal memory. It does a lot in terms of attention and concentration. It does help in terms of language skills and some visuospatial effects. So even if you just do a mini-mental status exam, you can identify some of the cognitive domains. There was the HIV dementia scale that was developed, a little bit of a harder test to do because it involves the anti-saccadic eye movement test. It also needs one to be literate and to be able to read and write. You time them writing the alphabet, they copy a cube, and there's recall and memory. So a nice test to do if you know how to do the anti-saccadic eye movement test, but also kind of very difficult to roll out in a clinic where perhaps nurses are not familiar with that test. But this is really the IHDS, the International HIV Dementia Scale. It takes 2 minutes to do, is very, very quick and easy to do, and it looks at motor speed, psychomotor speed, and memory and recall. And if we're looking at a subcortical type of dementia in these patients, and at least quickly one can really, really quickly screen, and I suppose kind of roll it out with nurses. Practically speaking, you get them to identify 4 objects. They must remember them later on after you've done the motor speed, which is finger tapping, and then the psychomotor speed, which is the Luria. I think everybody's familiar with the Luria, which is just, the hand sequencing. And you can tell a lot with hand sequencing. You can tell planning, you can tell organization, you can tell psychomotor speed. Finger tapping is just, basically motor speed, and then registration and recall. And it's out of a score of 12. If you get 10 or less, you must suspect a neurocognitive disorder. Then this is the more difficult neurocognitive battery, and this is the HNRC's battery from San Diego, which is a very comprehensive battery, but takes 4.5 hours to complete. And although you can get a very, very accurate printout in terms of exactly what cognitive domains are impacted upon, it's also, you can't do it. I think we've got like 2 neuropsychologists in this country, and they're all in Cape Town. So we're trying to find a nice medium between the two. So John Jonsson looked at this international HIV scale in South Africa, and he kind of found out that the sensitivity was about 45% and the specificity was 79% in terms of identifying neurocognitive disorders. He did feel that in our population it was deficient in executive functioning. So what he was saying is, do the IHDS, takes 2 minutes to do, and then just add a test in terms of executive functioning. So this is quite a nice thing that one can do. So you administer the IHDS quickly, 2 minutes. You then do the trail making A and B, and I'm sure you're familiar with it. Trail making A is just join the dots, 1, 2, 3, 4, 5 to 10. Trail making B is then joining 1A, 2B, 3C. And I mean, you can tell a lot of what the patients do in that in terms of, you know, attention, concentration, speed, even executive functioning, planning, organization. And then digit symbols forward and digit symbols backwards. You give them a number of digits and you ask them to please repeat it. And then the digits become longer and longer and longer, and you see, you know, how much they can remember. So I think that is quite a nice medium. If you do the IHDS, you do trail making A and B, and you do digit symbols, I think you get a really nice mix, which is quick and easy to do, and you can identify lots of cognitive issues. A quick investigation in terms of functional report, maybe a little bit of collateral, look at their work, look at their occupational, look at their social, and you've already made a diagnosis. Self-report, so what one has to actually look at is, you know, I mean, this plays a very important role, and all you can really ask them is, you know, are they able to manage their medication? Are they able to manage their finances? What is their independent activities of daily living, bathing, you know, grooming, what have you? And you can already, you know, but all it takes is somebody to do a little bit more of an involved history taking. Even if they are employed, you know, you've got to ask them about their efficiency, their productivity, errors, and, you know, does it take more and more time and more effort to, you know, do their job. All right, so Kevin Stoloff and John Jonsson then took those tests and they rolled them out in general HIV clinics. They took lay counsellors and then they also took nurses, and they just compared the two groups. And because, I mean, the whole idea is task shifting, and I hate that word, task shifting, but we've got to try and increase the diagnosis, and we can't do it all, so we've got to try and, you know, shift the task onto somebody else. But they found that the lay counsellors weren't that great in terms of administering these tests, and their pickup rate was higher than what it would supposedly be. So it's, you know, I think it, you know, goes with the training, and we've got to effectively train these people properly if we're going to expect them to do this kind of job. This is Dinesh Singh's algorithm in terms of treating neurocognitive disorders, looking at asymptomatic, mild, and HIV dementia. It's old and it needs to change, but I don't know what you guys think of it. HIV dementia, we all know, is a stage 4 condition, and you need to treat it with ART no matter what your CD4 count is. Mild, I think Dinesh is saying treat, but he's saying look at the asymptomatic neurocognitive impairments, and if they're, I mean, this is old in terms of CD4 count, but say they've got asymptomatic neurocognitive impairment and a CD4 of 400, would you or wouldn't you treat? What do you guys think? Because I really think that this bottom thing should be all of them. What do you guys think?
I think you're right. I mean, if you've got problems in your brain, rather get it under control rather than waiting until you are truly impaired. I mean, it makes a lot more sense, I would think.
Sure, exactly. So, I mean, that's kind of what I'm doing. I'm treating, if I diagnose any of these, no matter what I'm treating. Then the question comes in, what do you treat them with? And we'll get into that now. So, if we have to look at what have we done in terms of neurocognitive impairment with heart? Have we actually done anything? And I think we all very know that the neurocognitive disorders are a lot more since, you know, HIV has come about. But look what we've done in the heart area in terms of the sicker patients are okay, but look at the statistically significant, the less symptomatic ones, their cognitive impairment is a lot higher. So we've done nothing for that group of patients. You know, the Charter study, which was, you know, I'm sure you're all familiar with the Charter study, in terms of 1,500 patients, half of them had neurocognitive disorders. Look how much of them had asymptomatic neurocognitive impairment. Obviously, predictors are a lower CD4 count, a very detectable viral load, and the combination between the two. But I think what is quite important is this compartmentalization of HIV. You know, it's sanctuary sites and reservoirs, and our drugs are not getting to it. So that's something that we definitely need to look at, is in terms of getting a better drug penetration into the central nervous system. But on the other hand, then there's toxic side effects of some of the drugs, and we'll talk about efavirenz in terms of higher concentrations within the CNS. And then all of these other things like Hep C. I don't see a huge amount of Hep C in my clinic, but we've got a number of patients with Hep C. And I think all of these combinations together is as a result of why we're not doing too much in terms of treating the neurocognitive disorders properly and halting that progression. So if we have to look at the neurocognitive performance, I think early in the illness, you know, what heart has done is that it's really kind of treated the motor, the speed of information processing. It's done a lot for the subcortical stuff, but we've done nothing for verbal and learning memory and some of the executive functioning stuff over here. So this is the impact, and I'll show you just now in a case what some of the problems are. Now, this thing is quite important in terms of apathy, because I think it applies hugely in terms of our patients, and why aren't they going for testing? Why aren't they coming for treatment? Why, when you put them on treatment, are they not staying with treatment? Is this apathy as a result of depression? Is this apathy as a result of neurocognitive disorder? Or is it something completely different? And early in the illness, we kind of thought, well, you know, there was a correlation between apathy and neuropsych performance. There was 1 or 2 studies that, you know, associated it with depression. Then looking at Jackie Hoare did quite a number of studies in Cape Town in terms of looking at the white matter changes and the frontostriatal issues that HIV actually goes and impacts on. And I think that's where we're kind of going in terms of HIV destroying those frontostriatal structures and therefore causing this apathy. So, you know, bottom line is don't get HIV. Neurocognitive consequences of HIV in older adults. I think this is what's happening in this country, is that, and especially in America, a lot more patients are older on ART, and this combination of age, longer living, metabolic factors, Alzheimer's, beta amyloid plaques, all of those things put together are actually, you know, spelling disaster in terms of neurocognitive issues. Older adults, 3 times greater risk of dementia as compared to younger patients. And then there's this whole school of thought at the moment that HIV is that legacy event that actually lowers the threshold for developing, let's say, Alzheimer's or more cortical type of dementia as opposed to a subcortical type. Risk factors, we know, you know, the lower CD4 counts, anemia, different clades. Initially it was thought that clade B and clade C had different neurotropic effects. However, it's kind of been proved wrong. This comorbid Hep C and Hep B, together with age, together with HIV, together with anemia, together with nutritionally impaired population, I think all plays a huge role. Injection drug use, thank goodness we're not seeing too much of that. And then the medical comorbidities, vascular issues. And you can just imagine with our psych patients, now they're older, they've got Hep C, we've got them on olanzapine, they've got metabolic syndrome, they're gaining weight. You can just imagine what it's doing to their brain. Okay, so treatment is heart, and more heart. And we know that we've got to eradicate that reservoir. We've got to add adjunctive therapeutic drugs like lithium and like Ritalin, for example, and some of those things. Got to look at cardiovascular risk factors and dyslipidemias. You know, that's something that I think you guys do wonderfully well, but we've got to start looking more at that. Looking at nutrition, and I think Dave has done wonderful jobs in terms of that. Getting these patients to be adherent, getting them back to work is very important. But this thing, we're not doing enough in terms of cognitive skills training and rehabilitation, and I think the geriatricians are working nice and hard at that in terms of, you know, trying to rehabilitate demented patients. Okay, we all know that we need to start earlier, and we all know the NA Accord study and the Cascade trials and what have you, that you need to start earlier and quickly. And we know that the lower your CD4 count, the higher your odds ratio of developing neurocognitive disorders. That's, I mean, important. But we've talked about the legacy event and also, you know, treatment of prevention. And I think, well, treatment as prevention in terms of psych patients, you know, I think we need to start thinking about these kind of things. So obviously start earlier. If we have a look at, this is always a big question about, okay, so you've got a cognitively impaired person, you put them on a heart, you know, how quickly do they respond and how long does it take for them to respond? And are we seeing wonderful improvements? Well, Neurology 2009 said that at about 3 months we're starting to see an improvement, and peak around, you know, almost 6 months, and maximum at about 48 weeks. I don't know how you guys feel about that. Obviously, the more severely neurocognitively impaired you are, the greater the improvement. Higher CNS penetration index. Some studies have actually said that the better your penetration, the least neurocognitive impairment, or the greater the improvement. Some other studies have contradicted that. This was quite an interesting study in terms of patients that were on heart, stable on heart, suppressed, but still developing neurocognitive disorders. And, you know, they did a whole bunch of MRS studies, and we're finding that despite heart, we're not doing too much in terms of stopping immune activation and stopping that cytokine and pro-inflammatory cytokine response. So what about the CPE score, and do you guys kind of use this, and are you tailor-making your ART for these patients? Scott Luthando from the HNRC did wonderful studies in terms of taking the different ART, dividing them up into different groups in terms of what is their penetration through the blood-brain barrier into the central nervous system. And he divided them up into good, decent, limited penetrators and poor penetrators. And if you can see that nevirapine, zidovudine are great penetrators. Okay, abicavir, decent, lopinavir, decent, but look where tenofovir falls in terms of a very poor penetrator. So what do? We're putting patients on 3-TC, tenofovir and efavirenz. In terms of, if you agree with this penetration index, what are we doing in terms of helping neurocognitive disorders and treating them? I'm not too sure. So a lot of my patients are on 3-TC, AZT and lopinavir, and that's kind of what I'm starting them on. And I think, Dave, you've sent a number of patients to me on that combo, and I like it. I see them get well.
I think my worry, Greg, is that if you were to take the other combination of tenofovir 3-TC and the Eluvia, you're giving monotherapy to the brain, by and large. And there are issues with that.
Yeah. Yes, definitely. So,
so what do you give again?
Well, I'm combining 3-TC, AZT, so Combivir and Eluvia, or 3-TC, abicavir, and nevirapine sometimes I'm using. And they, obviously, a lot of my patients, when they come in, their CD4s are a lot lower than 200. So, I don't have too many problems with nevirapine. I've had a number of hypersensitivity reactions, but, we can deal with those. But Dave needs to talk about that, yeah.
So Doc, now that you recognize this compartmentalization of HIV,
yeah.
So in your choice of drugs there, it means you have in mind that the higher the viral load in the CNS, the worse of the patient. So you're trying to reduce that viral load in the CNS. So you're saying the viral load in the higher the viral load in the CNS, the more neurocognitive disorders. That should be. I'm sure that's the way you think. I don't know.
Yes. However,
I mean, if you were to use tenofovir, for instance, like we use tenofovir TTC, and you know, and we don't use the lopinavir, we use the efavirenz.
Yeah.
Efavirenz. And so what I'm saying, shouldn't we really consider the idea of a viral load in the CNS, the compartmentalization of the HIV as means of saying, this is how we're going to treat these neurocognitive disorders.
Okay, so I'm doing a number of CSF viral loads, and I'm sending them to Toga, which is great, but obviously, you know, we still owe the NHLS like 2 billion rand, so they're not that keen in terms of, you know, paying Toga for their CNS viral loads. So we have to work out a proper mechanism. However, there have been a number of studies that have just recently been released in terms of, you know, thinking differently about viral loads within the CSF, and is it that helpful? Dave, what do you think?
I mean, we don't do very many, but fortunately, by and large, severe neurocognitive disorder in people on antiretroviral is relatively unusual. But when I do get that, I do like to look at CSF viral loads. Our NHLS labs don't do it for us, and that is a big issue.
I've emailed Wendy Stevens and she refuses to get back to me. So maybe you could talk to her, please, in terms of...
I'll chat to Wendy. I do think there's an area where we should be looking at that.
Yeah.
And I think Clement's point is valid. We need to be doing that. We can't do it as a routine because you can't do lumbar punctures on everyone. But I think there is a place for it.
So kind of what I'm doing is, if I've got somebody who's on heart, who's suppressed peripherally, still has neurocognitive impairment, I've adjusted their ART to make sure that it's a decent penetrator and they're still neurocognitively impaired, then I kind of send it off. I'm doing a lot more in the adolescents, actually. And I'm finding peripherally suppressed, but centrally not that suppressed. And what do we do?
And you may well want to do a genotype. I mean, we've done now couples of genotypes on the virus in the brain and found it's a compartmentalized virus, as Tim was saying.
Sure.
So you need to be looking at that as well.
Yeah, and we need to look for money for that.
Well, I understand.
Yeah.
Greg, is there enough data to, once you've picked up that the patients have got cognitive impairment, to initiate on this regimen? Because I mean, that's what I think everyone wants to know. Should we start them?
Well, that's what I'm doing.
Yeah, no.
I'm changing regimens, and I'm just playing around with drugs, and I haven't run into problems yet, but I'm going to, you know.
I mean,
but then
differing from protocol.
Exactly. But I hate protocols.
Protocols is bad news. But what I would do is that if I got to that situation where my patient was, for instance, on Atripla, Truvada and Stockroom, and they needed the AZT, I'd add it on the Bill-4 drugs. I won't take anything away.
But then what's your second line regimen?
Oh, you can, well, no, you can, but because you guys go according to those strict protocols, which is very difficult. You know, once upon a time in the 80s, they told us that diseases don't read books, and certainly the medical aides didn't read that, because they think you can work out, you know, a flow diagram that fits every single patient, and we're all individual.
But I think that's what we're going to try and do with the Clinician Society and with Francesca and with Laurie and Lauren, and we're going to try and sit together all the psychs, and we're going to see, you know, is it something worth, I mean, we're going to take all the evidence, and is it worth putting these, you know, guidelines further? And we're going to, you know, look at the neurocognitive performance and what have you. So, I mean, sometimes I'm doing 3-TC, AZT, and Luthando, especially in the substance abusers, where I'm worried that they are going to default later on along the line. So, you know, in terms of resistance and stuff, sometimes I think it's a lot better to go that route, even though, you know, where do we go after that? But Dave's working on regimen 4, so we're lucky about that as well. So that's kind of where I'm heading. Then what I kind of do in those patients that still are not better on the neurocog, you know, on a very good regimen. So I'm adding things like lithium, which is a glycase synthase kinase 3 beta inhibitor, and works really nicely in terms of you know, simply putting, making your brain grow back again, you know, in terms of the neuroplasticity. You've obviously got to worry a little bit with lithium and tenofovir, which I'm seeing as being a big problem because it's renally excreted. But, you know, using valproate, I think, is quite great. I'm also adding huge amounts of Ritalin and stimulants, and that, I feel, gives them a nice boost. So that's something we can look at. And then there's all of this, you know, it's all of these studies going on about stopping arachidonic acid and the pro-inflammatory cytokines and all of those kind of things, and looking at that inflammatory response. We haven't had great results in terms of using the anti-dementia drugs. So adding anti-dementia drugs onto a good ART regimen, and that's certainly something that we need to be doing a lot more trials of in this country. But then on the other hand, there are the adverse effects of heart in terms of neurotoxic effects. We know from the study that I think that was done at the Gen, about 23% of the patients already are slow metabolizers of efavirenz. Their concentrations of efavirenz go up. Are they more predisposed to psychiatric illness? Are they more predisposed to, you know, the neuropsychiatric toxic side effects of ART? And certainly we know that some of the drugs, you know, if we take a look at neuronal markers and immune inflammatory responses and what have you, that we can definitely see that those markers are increased. So this was quite a nice trial in CID in 2010 in terms of looking at different combinations, and what they found out was that the people on the efavirenz arm did a lot worse in terms of neurocognitive performance. And in actual fact, those patients, some of them, there have been 1 or 2 studies that patients went on drug holidays for various reasons, not because their clinician told them to, but those ones on, you know, on heart, on quite high heart with CPE indexes of quite high, actually did better when they came off their heart in terms of neurocognitive performance. So, you know, this is all stuff that we need to be looking at, and this kind of half answers your question, Clement, in terms of we need to do a lot more research on this stuff. Age obviously predicts neurocognitive disorders, and in this study, they didn't see any link with CPE rank index and cognitive impairment, which is a problem because it like defeats what we've just all spoken about now. But you know, this is one study and there's been a lot more, and I think that's where we need to move toward. So efavirenz, everybody's scared of efavirenz. I don't know why. I use a lot of it. I see some of my very, very psychotic patients, I put on efavirenz, they don't get worse. And I use it a lot, and it works well in terms of especially those patients on TB treatment and all of that other kind of stuff. But you know, a lot of trials have been done, and only about 6% of patients actually had to stop their efavirenz because of the neuropsychiatric side effects. And yes, there are a number of patients that get bad dreams and dizziness and some central nervous system side effects. But bottom line is, I think that you don't need to be scared of it, and that sometimes when your back is against the wall, you may need to use it. But sometimes maybe when they've got cognitive disorders, perhaps then stay away from efavirenz in terms of if you want their neuropsychiatric performance to increase. A lot of the times, the moment you stop the efavirenz, some of those neurocognitive effects disappear. So between the highest time to get neurocognitive or CNS efavirenz side effects are really in the first 1 or 2 weeks of starting it, and they kind of disappear by 4 weeks. I mean, those were what the studies are saying. I don't know how you guys feel. I mean, the bad dreams in my patients seem to continue, but you know, the psychosis, depression, suicide, I wouldn't worry too much about that. So bottom line is, I'm saying use it. Don't not use it in a psychiatric patient. Okay. So this is something that we need to do. We need to look at preventing neurocognitive disorders. We need to look at this compartmentalization, toxic effects, the combination of the two, the combination with age, that we really need to start looking at, and we need to definitely integrate mental health care, drug abusers and aging populations, triple diagnoses and dual diagnoses. And I think, should we stop there?